So my previous speakers have already. So yes. So my previous speakers have already highlighted the importance of antenatal care. So we know that the women is at the center of this care. It's women centric, and our purpose is to have the babies also the best possible start in their life. So coming to the statistics, we have India has the highest number of children with birth defects. They affect about 1 in 33 infants. Many women don't even get even a single USG, as stated by Dr. Kiran Guleria also. As per NHM National Health Mission, only 25% of the women could get a USG in their throughout pregnancy. So one of the barrier for routine USG is the lack of adequate healthcare providers and trained staff also and doctors. So now coming to what are the guidelines, and then we'll discuss what should be our model of care for ultrasound in our scenario. So WHO in 2016 discussed about the routine antenatal care, as Dr. Monica Gupta had also summarized that it just one ultrasound is required, and that too before 24 weeks. And this single ultrasound will help us in estimating the gestational age, improve fetal anomalies detection and multiple pregnancies, the chorionicity, and also it will reduce the induction of labor for post-term pregnancy, and also will help us in managing suspected preterm births. So according to the WHO, just one scan, and that too in the second trimester around the time of anomaly scan, TIFA is required, and it will cover all our needs because it's not possible to have so many ultrasounds. So WHO, it acknowledges that early ultrasound does not reduce perinatal mortality. So if we are planning an ultrasound in the first trimester, it will not reduce perinatal mortality. And if women, they had an early ultrasound, that is after 24 weeks, then further ultrasound is not recommended by them. But if they had not had an early ultrasound before 24 weeks, then whenever she comes, then we can offer her a late USG. So in a Cochrane review of 11 RCTs, the women were randomized into two groups. All of the women had an early pregnancy ultrasound, and then they had an additional third trimester scan or selective scan only when there was certain indication for ultrasound, and then they found that late ultrasound had no effect. Additional ultrasound routine additional ultrasound had no effect on the incidence of cesarean section or instrumental vaginal delivery or induction of labor. Neither it reduced the perinatal mortality or the preterm births. So according to this RCT Cochrane review, just a single ultrasound in the around the time of 18 to 22 scan will suffice for our needs. And what NICE guidelines have to say, here NICE also, there was a systematic review of 7 RCTs, and they, for routine ultrasound after 24 weeks of pregnancy in low risk population, and they found after 24 weeks compared in routine ultrasound versus concealed or selective ultrasound after 24 weeks, and they found the antenatal and the obstetric neonatal mortality, and there was no difference in the outcome overall. So even the NICE guidelines recommends, they does not support the routine use of ultrasound scanning after 24 weeks of gestation, and it should not be offered. Now, what our National Health Mission has to say. They have recommended single scan between 18 to 19 weeks of pregnancy. And according to them, the routine scan in first trimester is of no benefit in low-risk pregnancies except for the diagnosis of ectopic pregnancy. And in ectopic pregnancy also, based on clinical grounds, if we are finding certain factors, then we can go for selective scan in those patients. So the single scan done at the time of anomaly scan around 18 to 19 weeks, it will help us detect the anomalies, and it will also provide us all the information what we want about dating, whether number of twins, the localization of placenta, the soft markers of aneuploidy, and any pelvic pathology also. And it is also the best time if there is any anomaly, and according to the MTB Act, we can undergo termination of pregnancy also. because in our settings, a single ultrasound scan, because women are not able to get even a single ultrasound scan, 75% of the women. So in that scenario, a single scan would be good enough. But my model of antenatal care, as Sadhana ma'am has asked me to represent my viewpoint. So my view is we should have 3 ultrasounds in each 3 trimester of pregnancy. It's very simple. First trimester, first trimester scan should be around 10 weeks and not around 7 to 8 weeks. This 10-week scan will provide us for the dating. We can know the viability. The second trimester scan that we have to do around the time of anomaly scan, that is 18 to 22 weeks. Here we can also know the cervical length and placental localization, and if placenta is low lying, or then we can further scan it at the 3rd trimester. And the third ultrasound should be in the 3rd trimester, where we can see the fetal growth, well-being, the fetal morphology and localization of placenta, the amount of liquor, cord round neck, everything we can get information from this 3rd trimester scan. So why I have recommended these scans, because we get all the information. In this 10-week scan, we can know about any missed abortion, the fetal heart rate, and morphological abnormalities many morphological abnormalities can be seen by this 10-week scan. And 22 weeks, 18 to 22 week scan is always recommended, and in 3rd trimester we can know other amount of liquor and placenta. So what ACOG has to say, ACOG, American College Guidelines, they recommend 5 scans. First is a dating ultrasound around 7 to 8 weeks. We always also exclude ectopic pregnancy, the number of fetus, and we can always date the pregnancy. Then the next scan is around 10 weeks. It will be a viability, and they can go for a first trimester serology of cell-free DNA along with this PAPP and beta STG first trimester markers on the same day. And next scan is around 13 weeks, when we can go for the nuchal translucency, and by 13 weeks also many of the anomalies can be seen, which we will discuss in the later. And we can also predict anomaly can be seen, and uterine artery blood flow and prediction of preeclampsia can be done. And the last scan around 36 weeks. Embryo is visualized, and gestational sacs 3 measurements should be there. If no embryo is visualized, then we have to need to measure the yolk sac. If yolk sac is solidified, or if it is more than 6 mm, that's a bad prognostic indicator. And then embryonic heart activity should be documented via M mode and not by power Doppler, because it's not that safe. And now we have to do the dating. So if the embryonic morphology is normal, and ultrasound dating before 9 weeks and 7 days differs by menstrual dating by 5 days, then we have to go for the USG dating. And between 9 weeks to 13 weeks, 6 days, if the difference with the menstrual dating is more than 7 days, then we'll have to use the USG dating. Otherwise, if the difference is less than 7 days, then we have to go for the menstrual dates only. What all information can we get from the first trimester scan? This is the size date discrepancy, the early pregnancy failure, ectopic or heterotopic. Embryo should be visible. And when the embryo is visible, cardiac activity should be visible when the embryo is around 7 mm or greater. And if the embryo is less than 7 mm and there is no cardiac activity, then we need not classify it as label it as a missed pregnancy, missed abortion. We need to do a repeat ultrasound after 7 to 10 days. So 7 mm, when the embryo is 7 mm, cardiac activity should be present. So means that position neither hyperflexed or hyperextended. It should be in the neutral position. The magnification should be proper, and proper caliper placement is required. Now see certain conditions where this is a wrong scan, because the fetus here is not mid-sagittal. The fetus here is flexed. It's not in the CRL measurements. So what in the early morphology and abdominal wall defect, cystic hygroma, hydrops petalis, and of course pentology. 6 days, and minimum CRL is 45 and maximum is 84 mm. So what should be the ideal position? The fetus should be in sagittal scan in supine position, and it should not be hyperextended or flexed. And we need to distinguish the skin from the amnion, proper caliper placement should be there, and fetal head and neck should occupy the entire image. So what are the various other... कोई बात नहीं मैम. So nuchal translucency, we know that in various aneuploidies we can cerebellum, cisterna magna. So I will just finish it in time. So in this fever length 4 weeks apart, and a single biometry assessment in the third trimester does not improve the perinatal outcome, and therefore is not recommended. And even the best fetal weight prediction models can predict fetal weight with an accuracy of only 20%. So, and biometry assessment more frequently, I mean, less than 2 weeks interval is not recommended. What about Doppler ultrasound? WHO does not recommend routine ultrasound Doppler in low risk pregnancy. Only in high risk pregnancy is recommended. That's also my viewpoint. So now CPR, these are all. Them to 2D ultrasound. So my viewpoint is just 1 USG in each trimester, and total 3 ultrasound should be there, and quality assurance should be there, trained staff should be there,